Good evening, Arun ma'am.
Hello, good evening. How are you?
Yeah.
So,
So, yeah.
I hope you have the introduction for all of them.
Yes, brief introduction we have.
Okay, all right. That's what I was only. And what about my presentation? Did it work or not?
So your presentation, the PPT is working, but the EA version, your
Sound is not working.
sound is not EA. So you have to do it live.
I will do it live. Okay, then I will do all live, huh?
Okay.
Mhm.
You can just check and share your screen,
Yeah.
whether it's visible or not. We can just check.
So, yeah, what I can, okay, I will share my screen,
Yeah.
but then I will probably, actually, I've kept it on.
Now you can share now, and then you have to stop sharing. Then once your turn again comes, we'll share it again.
Okay, so share screen. Are you getting my screen?
Not yet. Yes.
You got it? Okay. So what do you want me to do it now? Because this all has all the sound.
All the sound you have there, no?
Yeah, see, it's all recorded.
All record. Yes, and it's visible now. So you can run it from your screen
Yes.
also.
Yeah,
Yeah.
I'll run it from here.
Okay.
Yeah.
That's it.
I'll just be back. Huh?
Okay. So you have to do your
Unshare screen, huh?
unshare screen.
Stop
Yes.
sharing.
Stop sharing.
Okay. Okay.
Hi, everybody.
Hi,
Can
Pina.
you hear me?
Yeah. We can hear you.
Okay.
Hi.
Hi. How are you?
Yeah, I'm fine. Thank you. Nice meeting you.
Nice to meet you for me also.
Yeah.
Thank you for your kind invitation. I'm so happy and honored to contribute to this webinar in this important month for breast cancer awareness. And I think I am the last speaker.
Yeah. So
Yeah.
what you can do, you can just once share your screen so that we can check whether it's working or not. Then
Okay.
you can unshare and yeah, it's
Okay, just a moment. Okay. Can you see my slides?
Yes. Your screen is visible. Your slides are also visible.
Is
Yeah.
it okay?
Perfect.
Okay. So I'm stopping the sharing.
Yeah.
Okay. Okay. So it will begin, I think, at 4:30. Yeah.
Hey,
Yeah.
Pinar.
Hi, Arun. How are you?
I am good. So nice to meet you here. Thank you
Yeah, for me
accepting.
also. Thank you. Thank you so much.
So you meet our very young and enthusiastic Dr. Suman Das from Kolkata.
Yeah. I think we have met before. I'm not sure.
No,
No,
we had,
this is our first time. Okay.
Yeah.
because
Okay.
Dr. Pinar, Dr. Suman, she had come to Kolkata 23 or 22? 22.
22, I think. Yeah.
To
Okay.
Kolkata for vascular society meeting.
Okay.
So that was vascular surgeons. He's a cancer surgeon.
Oh, very nice. Very nice. Yeah. Okay. Breast cancer, dealing with only or every cancer?
No, we do all, but my area of interest is breast. Mostly my work is more than 50% work is breast work.
I see. It's very important. Yes, for prevention of lymphedema, also, do you apply techniques like LVA and other techniques? No?
He's using some. He's using
He's using? Okay.
lympha or something you are doing, no?
Lympha I'm doing. Lympha we
Lympha
are
he's
doing.
doing. So in
Yeah.
India, Pinar, it's very interesting. Lot of surgeons are now doing lympha. Even
Yeah.
we were
Yeah.
surprised. We recently attended a EPSICon in Coimbatore, and we were
Uh-huh.
surprised to see how many surgeons are doing it. Even general
Yeah.
surgeons are doing it. You know that the younger ones.
Yeah.
Yeah.
It's
Yeah,
great. It's great. It's not so
very
common in Turkey, actually.
good.
Not so
Yeah,
common. Only in very rare special centers it is done in
yeah.
Turkey. Yeah.
So some people are also have started doing S-Lympha, the simplified one.
Acha,
Yeah.
what is
Yeah.
that?
Yeah. Yeah.
So that's
I
a simple stitch with a 9-O-proline. So that's an easier version. But we are yet to get the raw data of it, whether that's as effective as Lympha or not. We are yet to uh,
yeah.
get the data of it, right? So
Yeah.
But I
Yeah.
think most
yeah.
important here should also be the choice of patients, because I was talking to Dr. Juhi. She's a
Mm.
plastic surgeon. She was saying that we really have to choose patients. Like if we choose a wrong patient, then the thing doesn't work. So
Yeah.
that I think will still take some time to. So anyway, establish.
Selected patients. Yeah.
Yeah.
It's useful in selected patients. Yeah.
So Dr. Das, let me tell you, Pinar, my friend, is present president of ESL, European Society of ESL, right?
Yeah.
ISL.
Excellent. Excellent.
ISL is International Lymphedema Society. That she's doing next
International.
year.
Okay.
This year, yeah,
Excellent.
yeah. We would
Congratulations.
like to see you also, Dr. Das, inshallah, in our ISL 2025, which will be held between 15 to 19 September in Antalya, a very
Okay.
nice place of Turkey. And now I'm in Antalya, Arun. There's
Oh, you're in
now we are
Antalya.
having National Congress, Physical Medicine and Rehabilitation Congress. We are
Oh,
here,
oh,
and I have just completed a course on injections for musculoskeletal
oh,
pain, and now I have reached here, and this is great. Now
thank
it's the
you.
best time for Antalya. Not
Oh,
so hot, not so cold, and you can swim also in
wow.
at the seaside. Yeah.
I believe you have a home also in Antalya, an ancestral home or something?
Yeah, we have home, but we generally not come here. We go to Bodrum to the
Oh, Bodrum.
Aegean
Okay.
Sea part. But we have a house, seaside house. Yeah,
Oh, okay.
our
Okay.
relatives are
Mm,
commonly
mm,
coming and staying there. Yeah,
mm. So maybe Dr. Das will call you again in Kolkata. She's been to Hyderabad and Kolkata, right?
yeah, yeah,
Pinar?
Yeah, sure. I will
yeah,
call you.
yeah. And also Delhi,
Delhi,
Tally.
yes. Hmm.
Okay.
Mhm.
Delhi. Yeah, Kolkata, Hyderabad. Yes. This year, I think it has been in Indonesia. The vascular UIP has been completed, I think. I couldn't
Yeah, it
attend,
was
but
in Bali. A lot of people were there. We didn't go. Hmm.
did you go?
No, we didn't go.
Yeah,
We
okay.
didn't go. Hmm. Did you? You didn't go either, right?
No, 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 no.
Hmm. But a
So,
lot of people from our
Arun
sorry.
ma'am, Dr. Pinar, let me introduce Dr. Rahul Agrawal. He's a co-consultant. He's a surgical oncologist here in Netaji Subhas Cancer Hospital, Kolkata. He will be coordinating the program. He will be calling the speakers and all this. So Rahul has
Oh,
taken a lot of pain to organize the whole thing. These Zoom links, emails, and all these being done by this young chap. Rahul, you can start things.
thank you, Dr. Rahul. Thank
Nice
you
to
so much.
meet you. And thank
Meet
you for
you.
all your efforts, Dr. Agarwal. Yeah. We cannot hear you. Your mic is closed.
Okay, I'm sorry. Glad
Okay.
to organize and really honored to meet you all. Just a small request. Can we just wait for 5 more minutes? Maybe a couple of people are joining in. So
Sure.
maybe
Okay,
we'll
so
start in
tell
five
me
minutes.
how many registrations do we have, Doctor? You have any idea?
Yeah.
Around 113, ma'am. We have confirmed registration.
Excellent, excellent.
113 confirmed registrations, and we have a capacity of taking 300 people here, and we are broadcasting it in our YouTube channel also. I can see there are 10, 15 already they are watching live, right? They have started watching it live in our YouTube channel. I have kept it open here.
At the end, I will be very pleased if you take a picture of all together, all the
Sure.
speakers together as a memory, and I will. You can send it to us later after the
Sure. We'll do
webinar.
that.
Yeah.
We'll do that.
तुम्हें अपने उससे जाओ ना जो तुम्हें मेल आई है मेल से अच्छा okay so Dr. Gogia can't turn on his speaker and
Okay,
video. Is that
I'll
you
do that. I'll do that. Ma'am,
Yeah,
has
yeah,
he
yeah.
joined? Has sir joined us?
He has joined. Yeah, he has joined.
Shashi, this one.
So, Shashi, okay. I'll just make sure he is able to join. Just give me a minute. Yeah, sir, can you please check if you are able to unmute or not?
No, I can't.
शशि लाइट तुम्हारी ठीक नहीं है शशि
This is better.
Yeah.
This
so
light is
yes.
better?
Yeah, we can see you. We can hear you also, sir.
Okay. No, it's okay. Hi, Pinar.
Hello, Dr. Gogia.
Hi. Hi,
Hello.
Dr. Suman.
Nice meeting you. Nice meeting you. I heard lot about you. We didn't meet.
Well, we're meeting now.
Yeah.
Hi, Dr. Shashi. How are you?
Pinar.
Nice to see you again.
Yeah.
Is Dr. Shuba coming?
Yeah, he has sent his presentation, recorded version. He will come during the discussion.
Okay.
So I think Dr. Rahul, you coordinate. We'll start on time if things are okay. We have still 1 minute time.
So we
We'll
can
start
take
sharp
a
at 7.
picture.
Yeah.
We can take a picture. Pinar wanted to take a picture.
Yeah, sure. I'll take a.
My light is not good.
I'll take another.
Okay. So I'm just going to
Hmm.
get my light right.
So, Dr. Suman, did you download our videos? Because the problem is I
Your
have now
one
removed
is
the
okay.
video.
Your one is okay. Arun ma'am's presentation.
What I meant was, if
But-
you have downloaded it, fine, because now I've removed the video from all of them. So, I mean, if it goes off from here, then it'll be without the video.
No, sir, we
So
have
that
it.
same
We have
link
it.
will be-
Your
Yeah,
one is absolutely fine. Arun madam's, I think she showed us this from her end.
I will run mine from here only. You know?
Yeah. I take another photograph once we make it.
So, Pinar, Dr. Zuba will also probably join us. He's also in a meeting. He said he will try to join. And Bill also just might join. No, Bill said he's traveling.
Yeah.
Yeah, he's traveling. So you also know the classifications of how many people, like how many surgeons and therapists, and that have you taken that also? Data.
Yeah, Dr. Rahul knows that. We
Achha.
have that data.
Yeah, we have that data, ma'am. If I tell you exactly, then we have around 47 guys in general surgery, around 21, around 18 in surgical oncology, 3 in medical oncology, 7 radiation onco, 12 in breast surgery exclusively, 3 plastic surgeons, and there are 2 endocrine surgeons, and around 21 other specialties, ma'am.
Okay, could be physiotherapists, sure.
Yeah, probably there.
We also got a couple of calls that our specialty is not here.
Yeah, that I told Dr. Rahul yesterday. Even the
So
plastic
maybe-
Yeah.
group we included yesterday.
Yeah, I would apologize, but that was my
No,
bad.
no, it's okay. You
Yeah.
can't think so much. Actually, I also yesterday only we circulated. That is why that's how people got to know. If we had more time, we could have circulated earlier, but it always happens like this.
we wait to start.
Yeah, I think we can start. Good evening, everyone. On behalf of Institute of Breast Diseases, I would like to welcome our esteemed faculty and the delegates for this enriching discussion. Now, as we all know, breast cancer is the most common malignancy diagnosed in women. Though we have made significant progress in treatment of such patients, now patients are living longer, but some complications are setting in. One such complication is lymphedema. Millions of women worldwide have to suffer this complication and have to live with it. Today, our motto of our discussion is to have an insight on this dreaded problem and how to manage this. With this note, I would like to welcome Dr. Somen Das. He is a senior consultant and head of the department in the surgical oncology, Netaji Subhash Chandra Bose Cancer Hospital, and he is also the founder and director of Institute of Breast Disease of Kolkata. Over to you, sir.
Thank you, Dr. Rahul, for the generous introduction. I will now share my screen. Yeah. So is my slide visible?
Yes.
Thank you.
Yes, yes, visible.
So at the outset, I'd like to thank the LEARN team and Arun ma'am for giving us the opportunity to organize this webinar on breast cancer related lymphedema. So the background of this webinar is we have an increasing incidence of breast cancers in India. It has already touched 1.38 million per year new cases. And this is the cancer presentation in India. We have a high incidence with high mortality. But if you can look at the data on the stage-wise survival, we can see if the stages are increasing, the rate of survival is going down. So in India, we are having high incidence with high mortality, right? Those who are surviving, they are mostly locally advanced breast cancers, and they usually undergo ALND or axillary lymph node dissection, which gives rise to a dreaded complication called lymphedema. We all are aware of the different cancers who can give rise to lymphedema in the extremity or in the trunk. Now, this patient who have survived the cancer is living with a swollen arm. So this gives her a stigma that she had a cancer and she will bear this through lifelong. So this pain of having a cancer-related lymphedema is really going to bother the patient throughout her life. So this is the situation of breast cancer-related lymphedema, and that's why we are organizing this webinar, and we are tying up with Learn international team and Indian team so that we can overcome this situation. Now, if we go into the details of the breast cancer related lymphedema, they are either disease related, which gives rise to lymphedema in the breast, and they can be treatment related. Either a radiation or a surgery of the axilla will give rise to some sort of lymphedema. We can divide them based on the anatomical classification, edema in the breast and chest wall, which usually is a result of the disease itself, and the edema of the extremity, which is a result of the treatment itself. We all know the different stages. We'll be discussing this later on. Our other speakers will be discussing this. Now, what are the risk factors of breast cancer related lymphedema? BMI of more than 25 is a risk factor for developing breast cancer related lymphedema. Type of surgery, we all know that a complete axillary dissection has got a higher chance of developing breast cancer related lymphedema in comparison to sentinel node biopsy or a lesser axillary surgery. Radiation in addition to surgery will obviously increase the chance of breast cancer related lymphedema. Taxane based chemotherapies, it has been shown that they are the association factors, right? So they are not directly, but indirectly they will increase the chance of breast cancer related lymphedema. Now, we had a feeling that doing sentinel node biopsy is actually free of lymphedema. But here you can see, if we do a lumpectomy with sentinel node with a whole breast radiation, the chance of getting breast cancer related lymphedema is 3 to 23%. So any sort of axillary surgery with a radiation will give rise to a chance of lymphedema. So we need to be careful about that. How to manage the situation, I will just briefly touch upon few points. Prevention is better than cure. It is always advisable to prevent lymphedema. If we have to do some radiation or breast axillary lymph node surgery, we need to be careful about its early diagnosis. We need to be careful about the lymphedema signs and symptoms. We need to screen for lymphedema so that we can pick it up at an early stage. And if it happens, we need to treat it at an early stage. Now, the whole idea of preventing breast cancer related lymphedema is axillary de-escalation surgery. Previously, we used to do complete axillary dissection, axillary node dissection up to level 3. We need to de-escalate this to achieve lesser lymphedema. In node negative axilla, the standard of care is sentinel node biopsy. We all know the sentinel node is the first node in the axilla where the cancer drains. If we identify that sentinel node, we take it out and we send it for histopath or a frozen section. If we see this is negative, then the rest of the axilla is possibly negative of a cancer cell. Now, sentinel node biopsy is done usually in upfront setting. We can do sentinel node biopsy even after neoadjuvant chemotherapy because most of the Indian patients are locally advanced breast cancer patients, or those who are early breast cancer patients nowadays, if they are HER2 positive or TNBC, more than 2 centimeter tumor or any node positive will have a sentinel will have a neoadjuvant chemotherapy. So if the patient is node negative to start with, we can do sentinel node after NACT. We have trials for that. If the patient to start with is a node positive, after neoadjuvant chemotherapy now becomes node negative, we can still go ahead with a sentinel node biopsy in those patients based on some sentinel data and few other data. If the sentinel node comes negative, then no further treatment is required. No further axillary dissection is indicated. Now, we have, if the sentinel node is positive, then the standard of care is ALND or axillary lymph node dissection. Now, question is, can we avoid ALND in sentinel node positive cases? Can radiotherapy be an alternative to surgery? Amaros trial has looked into it, and it has shown that if we don't go for a complete axillary dissection, we give RT, that will give you a equivalent result. Now, we can avoid doing surgery or radiation if in some group of sentinel node positive. This data was looked into by ACOSOC Z11 trial, and that has recommended that we can omit axillary surgery in certain group of patients. Now, the sound trial has come up, and this shows in very select group ERPR positive and small tumor less than 2 centimeter, we can omit both surgery or radiation safely, right? But larger data we require to confirm this. Now, if the patient is node negative, the standard of care is not to go ahead with any further surgery. If node positive, even now, the standard of care is to go for an axillary node dissection. And we all know axillary node dissection is associated with higher chance of lymphedema. Now, to prevent this lymphedema during the axillary dissection, we can do something. What are those? We can go for an axillary reverse mapping, where, as we all know, the lymphatics from arm and lymphatics from breast are little different. So we need to preserve those arm lymphatics and we need to take out those breast lymphatics. And by that, we can actually avoid lymphedema to some extent. But what if there are higher nodal burden? We then inadvertently, we sacrifice the arm lymphatics. And there we have an option of going for primary lymphovenous anastomosis. The details will be told by our subsequent speakers. Here, what we do, we anastomose the arm lymphatics with the veins there in the axilla so that the arm lymph can drain into the vein directly, right? This is one method by which we do it by pushing ICG as well as with the help of the ICG camera. We find that whether the arm lymphatics are draining directly into the vein or not, whether they're intact or not, we got it lymphacheck. If they are damaged, we then do a lymphatic anastomosis, lymphovascular anastomosis. Now, the strategies are to increase the number of sentinel node biopsy wherever possible. We can do a targeted axillary dissection. We are de-escalating the axillary dissection surgery even after post neoadjuvant, and axillary reverse mapping, where we are forced to do axillary dissection and go ahead with an axillary lymphovenous anastomosis if possible. Now, early diagnosis is the next step, and which most of the centers are now following. It should start before surgery. The measuring the arm lymphatics, arm circumference before surgery is important, because if we compare both the arms, there will be some difference, right? So start from before surgery and in every visit, and this should be done by the breast surgeon or the medical oncologist himself or herself. Because if we can diagnose lymphedema at an early stage, then we have a lot of options to treat that, and most of these lymphedemas are reversible. We will learn more about this in later presentations. So to conclude, I must thank the Lymphatic Education and Research Network, or LEARN Network International, and my special gratitude to Arun ma'am. She took the initiative of this webinar and connected me with the LEARN Network. We, on behalf of NCRI Hospital and Institute of Breast Diseases, we have tied up with LEARN to increase the awareness among the colleagues in this part of the country, among the patients of this part of the country. We will educate them. We will increase the awareness on lymphedema management so that no patients of breast cancer suffers from a lymphedema. We will try to prevent it. Where we fail to prevent it, we will give utmost care so that all the patients with lymphedema can have a good life. With that, I conclude. Thank you very much.
Thank you, sir, for your enlightening talk and enlightening us on the extent of the disease and the possible management options. We are grateful to have faculties from all over the world joining us. Moving on to our next speaker, I would like to welcome Mr. William Repici. He is the president and CEO of Lymphatic Education Research Network from New York, United States. Now, he has kindly sent us a video regarding the Learn Network, and we'll just showing this.
Hello, everyone. It is my profound honor to join you today for this webinar on breast cancer related lymphedema. My thanks to all of the organizers and especially to Dr. Suman Das, who heads LEARN's India chapter in Kolkata. I also want to thank Arun Rekha, our LEARN India chapter founder, for her tireless efforts on behalf of those living with lymphedema and other lymphatic diseases. When I began in this field 13 years ago, I was mystified by the silence globally about lymphedema. Here was a disease that affected up to 250 million people, and yet no one seemed to have heard of it. Not the public, not doctors, not even the people who were living with the disease. Up to 30% of women surviving breast cancer surgery would then get lymphedema without ever being warned of the possibility, and without any attempt on the part of hospitals to mitigate the onset of the disease or to prepare patients with a treatment regimen. How is this possible? In part, women have traditionally suffered at the hands of a male-dominated medical profession. However, another problem was that without medical treatments available, medical schools didn't teach the lymphatic system. Uninformed doctors failed to diagnose the disease. And when a patient got LE, our acronym for lymphedema, surgeons most commonly told them, "I cured your cancer, find a therapist, don't complain." Those days are over. And thanks to the efforts of groups like the Institute of Breast Cancer and NCRI Hospital Kolkata, who bring you this Breast Cancer Awareness Month. And now with your support, LEARN has succeeded at many new agendas that will help transform and speed new treatments. Together, we now celebrate World Lymphedema Day on March 6th, an event LEARN established in 2016 that now spreads awareness and advocacy globally. We now have a National Commission on Lymphatic Diseases, which was congressionally called for at the National Institutes of Health. And our success with a new government medical research agency called the Advanced Research Projects Agency for Health to get a lymphatic research program could put as much as $200 million into the search for new treatments and cures of lymphatic diseases over the course of the next 5 years. We now have over 70 centers of excellence in the diagnosis and treatment of lymphatic diseases around the world that provide state-of-the-art care. One of those centers is run by Dr. Sasha Goja and Arun Rekha here in India. In our effort at LEARN to improve treatments, I offer you here one document that we created this year. You can download it using the QR code on the screen. Standardized approach for the management and diagnosis of lymphedema and lymphatic diseases. This document compiles the expertise of dozens of global leaders. I also invite you to visit LEARN's Lymphatic Resource Center, where you will find over 100 educational video symposiums by world leaders in lymphatic disease focused topics such as therapy, surgery, research, and the mental health of patients. Thanks to the efforts of people like Dr. Suman Das, Arun Rekha, and all of my friends on the panel, there is no turning back. Thank you again to the Institute of Breast Cancer for their leadership and for inviting me and LEARN to join you on your journey to improving the physical and emotional health of those living with lymphedema. Once again, thanks and have a great webinar. Bye now.
Thank you, sir, for this enlightening words. He might soon be joining us in this webinar. Moving on to the next speaker, we are privileged to have Professor Andres Zuba. He is a professor of medicine and head of the department in the Department of Angiology, Hypertension and Diabetology in the Wrocław University of Medicine, Poland.
Good morning. I would like to thank the organizer for inviting me to this important webinar, and I'm sorry not to present it live. The topic of my lecture is lymphatic anatomy, physiology, and causes of breast cancer related lymphedema. I have nothing to disclose. What is lymphatic system? It is organization composed of interstitial space, body cavities, and lymphatics containing tissue, fluid, and lymph, migrating immune cells, and organized lymphoid tissue. The lymphatic system is present in all organs of the body, including central nervous system. It is especially abundant in organs with direct contact with external environment. The structure, the lymphatic system and venous system are the main outflow system of the circulation. The lymphatic system begins with initial lymphatics, which are blind and the sinuses, and the interstitial fluid can enter this sinuses between the cells. Then the fluid is transported by the pre-collecting and collecting lymphatics by the contractions of lymphangions. Our body produces about 8 liters of lymph a day, and this lymph comes to the lymph nodes where it's concentrated, and about 4 liters of lymph is transported from the lymph nodes to the subclavian vein. About 25% of total lymph comes from the liver. Initial lymphatics are interesting because the endothelial cells are loosely joined together by button junctions, like you see on this picture, and these flaps can open and the lymph can freely, the interstitial fluid, which becomes a lymph, can freely enter the lymphatic capillary. And the further junctions between endothelial cells are zipper junctions that don't allow fluid to come in and out. Well, this is important because that what was found that maybe transition from button to zipper junctions in the initial lymphatics, not allowing the fluid to come in the vessels, like it happens in lymphedema, progression lymphedema. And such a transition was also found in early stages of breast cancer related lymphedema. Have many important functions, like immune functions, but also they concentrate the lymph coming from the organs, and it is more than just a concentration. The postnodal lymph have higher protein concentration than the prenodal lymph. However, not only the concentration is changed, but also the protein content is quite different between efferent and afferent lymph. Lymph flow is maintained by lymphangian contractions, and it has systolic and diastolic pressure. Under pathological condition, the pressure can be, however, much higher. Traditional associated processes with lymphatic pathology are lymphedema, tumor metastasis, and inflammation. However, recently was found that lymphatic systems plays important role not only in lymphedema but also in probably majority of human diseases. Coming to lymphedema, it is edema caused by lymph stasis, accumulation of water, proteins, glycosaminoglycans, cells, and soil debris, which causes chronic inflammatory process leading to fibrosis and proliferation. The fluid, however, is not protein-rich fluid like in many books you can find, but it's rich by, with glycosaminoglycans. What happens after dissection of axillary lymph nodes? The lymph have to find a way to different nodes, supraclavicular, axillary on the other side, or inguinal lymph nodes. And this is typical lymphocytographic picture of breast cancer-related lymphedema, that we don't see lymph nodes on the affected sites, and we see dermal backflow or collateral lymphatic flow in the skin. What happens with lymph stasis was found on this MRI study that showed that in affected arm we have more fluid, but also much more of fatty tissue. It is, of course, breast cancer-related lymphedema. And this quite famous picture from Hakan Brorson shows autopsy of a woman who died from breast cancer, and we see lymphedema. There's almost no edema, this overgrowth of fatty tissue and skin. How common it is? Breast cancer-related lymphedema happens from 11 to 68% of patients treated for breast cancer. With sentinel node biopsy is less, but still lymphedema can be present. What are risk factors? There are personal risk factors like BMI, and the higher weight, the more likely a woman can get lymphedema, postoperative weight increase, ethnicity, and disease-like factors like hypertension, cancer stage, and tumor size. Also, breast conservation surgery might be helpful, and actually it diminishes the risk of lymphedema, as well as a sentinel node biopsy. Number of lymph nodes dissected, neoadjuvant chemotherapy, taxane-based chemotherapy, radiation therapy, and complications.
हेलो, तुम्हें आवाज आ रही है?
No, I can't hear.
Yeah, you. Hello.
Hello.
Yeah, now it's better. Yeah, we can hear you. We lost the connection in between.
Okay.
Has the video has been stopped or what?
So I think you switched on your screen sharing. That's why I kindly request you to stop your screen sharing. We'll restart the
I
video.
didn't.
Yeah, I think so.
No, I didn't. I don't know how it came. Sorry, I don't know how it came.
And actually it diminishes the risk of lymphedema, as well as a sentinel node biopsy. Number of lymph nodes dissected, neoadjuvant chemotherapy, taxane-based chemotherapy, radiation therapy, and complications.
My screen sharing is not this thing.
No, it's something else. Shashi, अब तुम्हारा screen share हो रहा है?
No. That's his.
Yeah,
He's
it's
showing
okay.
my.
It's okay, ma'am. It's okay, ma'am. I have done it. I would like to thank Zuba sir for his enlightening discussion. That much video what we had with him. For our next speaker, I would like to invite Dr. Shashi Gogia to enlighten us on the treatment approach and surgical methods of lymphedema management. Gogia sir is a lymphedema surgeon, and he's the president of Sathi and director of Virtual Sathi Private Limited. Over to you, sir. I think we'll start your video.
Thank you. Yeah. Okay. Sorry, I don't know. I didn't. Anyway, now it's switched on the screen share. Can you see my screen?
Yes, sir. Yes, perfectly fine, sir. So
Yeah.
you can
So
switch on the full screen mode, sir. Screen share. Yeah, this okay.
Yeah, okay. Thank you, Dr. Suman Das and Arun Rekha for inviting me for this work. I've been allotted to talk about lymphedema treatment approach. Although Dr. Suman has already mentioned a little bit of this, so I'll skip over the point that he's already mentioned because time is short. Just this screen is important because what we are showing here is that lymphedema is a problem since ancient ages, and these are from the statues found in the Konark temple in Puri. And you can see the lymphedema in the female and the hydrocele in the male. So it was interesting that to show. Anyway, just to come to what following up what Dr. Suba said, I just want to emphasize that normal lymphatic flow is 10% of the needed capacity. Capacity is 10 times. And when that capacity is exceeded, you get lymphedema, which can occur routinely because of various reasons. But the thing that is surgical can treat this fall is all permanent. Surgery can improve it 10 to 20% of the fall in capacity. So if it's down to 4 to 5, it will come to around 6, 7 or so. So earlier done, it is better. That is what I want to emphasize, because earlier you can come back to normal. And it has to be done early. And the goal behind doing lymphatic flow surgery, and this is what you're talking about, lymphatic flow surgery, is that you can avoid the conservative care in the form of CDT, which will be told to you next time. So basically, just coming back a little again to the pathophysiologist, Dr. Suba has already said, there's an imbalance between demand and flow. This leads to a stagnant body of fluid, which is the culture medium. This leads to repeated infections, and this infection is generally gram-positive and sensitive to penicillin. And this role of penicillin is something which needs to be emphasized again and again, especially in India. And this is where we found a lot of remarkable, just by giving them benzathine penicillin every 3 weeks. And of course, this fibrosis further block, and this has already been explained. And finally, you get lymphedema. I don't want to spend too much time on this. Just talking about post-national lymphedema, it's already been said about what are the reasons. So the gap in lymphatic flow, the alternate path may or may not compensate. The other thing that is causing lymphedema is the absence of lymph nodes, which means the immunogenic reaction and solid tissue breakdown in the glycolines, like you were saying, breakdown is decreased, which increases the chance of bacterial infection. This is very important. It's not only the flow, but the absence of lymph node is also adding to the propensity for infection. So you have to also put in back the lymph nodes wherever possible. Before you start treating lymphedema, you have to quantify in the form of volume measurements and photographs. We used to do water displacement, but now software is better. I don't want to spend time on this. Special investigations are very, very important. They've already been listed out. I'll just talk about 2, 3. One is bioimpedance and myostometer. These are not available in here, but they help in finding out early lymphedema. Of course, the signs of early lymphedema, we all know. I'll again not spend time on it. Lymphocytic scan is important for the deeper lymphatics. And for superficial lymphatics, and especially if you are going to do surgery, then ICG is important, because ICG you can do on the spot in the OT and ensure that you are using the proper draining system of the lymphatics into the vein. The newer this thing is ultrasound and ICG. I'll just show you, which is just like what was shown by Dr. Suba. The ICG can also show the dermal backflow, but it can work only 1 to 1.5 centimeters beyond the skin. Otherwise, it can't deal with the fluorescent test. MR lymphography is done through a subtraction technique. It's now started being available in India. Again, you can trace out the lymphatics by putting the injection just you do for lymphocytic scan or ICG. But after that, that shows all the vessels. You have to do subtraction by doing a proper MR venogram, and then you can see the lymphatics, as you can see on the right. High frequency ultrasound is a new technique which has recently come in, not available in India as yet. You have to use a probe which is 40 to 72 megahertz, and you can actually see the lymphatics while they are draining, and it can probably obviate all other tests, because you can use it at the time of surgery also, and you can actually see the vessels, as you can see out here. But basically, to tell you, when you talk about the surgical aspects, we all simply say that it takes 5 years to learn how to operate and 10 years to learn when not to. Lymphedema, a lot of people know how to operate, but you have to be very careful because the results are not so remarkable. They are, as so far, they are being overrated. But yes, with time, currently the results, I will show you some of them. But the important thing is you should not do lymphatic surgery unless you have the full team in place in the form of therapists who will train the patients to do the self-care at home. 70 to 80% of care is self-care. So these are the various surgical methods in lymphedema. First of all, any surgeon has to do this job is to drain pus and also improve drainage. It's a physical block. You can improve the draining. As I said, 10 to 20% improvement can be done. It is done through various methods. Nodovenous shunts are only possible in filariasis because here the nodes are not there. Lymphaticovenous shunts and node plants are transferred. Talk a little bit about it. Professor Olsey has started a method of what is called silicon tube implantation. We have done a few. In upper limb, it may work. Lower limb, we had a lot of problems. In which I'll talk a little bit about that. Of course, general surgical needs for other things, sequential excision, skin grafts, debridement, maggots, etc., are important to improve the hygiene. Debulking is done for cosmetic as well as functional reasons, and liposuction, as Professor Suba said, for advocated by Hakan Rosen, is also a form of debulking. Basically, it reduces the limb size, and you need to follow up by a lot of compression therapy after that. Other miscellaneous things I will not talk too much about. But the most important reason for this thing is acute and persisting infection. If there is a pus, you have to drain it. But do not operate for lymphoria. A little bit of drainage is better managed conservatively. So those are the advances in lymphedema surgery for the last 10 to 15 years. The most important is the lymphaticovenous shunts, which came up because of ICG and better investigation so that you can trace the smaller lymphatics. It requires super microsurgery. Node transplants is another one. There are variations to this. And silicon tube. I'll talk a little bit about each of them, as well as liposuction. The important thing which Dr. Suman had mentioned is what is called the lympha technique, which is lymphatic microsurgical preventive healing approach, direct lymphatic to vein anastomosis at the time of primary breast cancer surgery. And post this surgery, reduction in incidence as to 5% instead of 25 to 30%. So this is important, which has come up. And Dr. Suman, are you doing this or not?
We are doing S-Lympha. We are doing S-Lympha.
Great, great. So I don't need to talk too much about it. Okay. So the lymphaticovenous shunts were started initially by Campisi, O'Brien, and all that, in which initially what they do is they used to pick up a lymphatic and make a small slit in a vein and just stitch it in, because at that time direct lymphaticovenous surgery was not possible. Now it is possible to do it with 11 or 12 sutures, and Cosima and Mihara and Marcia in Spain are doing it a lot. They say that now the recovery rate is around 30%, but again depends on if it is done early. We're not still, the results are not so sure, and do not do it in active infection. Make sure that it is done earlier than later, is what I want to say. And this is a direct lymphaticovenous surgery. You can see the slide in which direct anastomosis is done. And as I told you, the results are, Kohima, who started this, said is 7% total absence of compression therapy required. Otherwise, other people, it is. So some people consider reduction in the need for conservatism also is the reason they say that the results are better. We don't know. Vascularized node transplants for the breast are best put in this is done after the breast surgery has been done. And in this, you pick up a node from a place. Initially, they started doing it from the groin, but now they believe it is better taken from other areas, obviously not from the dependent side. And you have to do what is called reverse mapping to ensure that there's no donor side lymphedema. You can also do it during the primary breast surgery by picking up the nodes along with your recto abdominis flaps, if you are going to put that. So this I've already told you. You can also take it from the jejunal mesentery or omentum, but you have to create good space to put it there and make sure that your anastomose, so only the artery and vein anastomose, it gives a lymph node back. The lymphatics are supposed to come back on their own. And it has been shown on ICG that they do to some extent. Silicone tube drainage for this, unfortunately, I have photographs only of a child in which we did in primary lymphedema. He did improve to quite a extent, and in which the lymphatics start flowing around the tubes, not inside the. You put 3 tubes and put them from the most dependent the dorsum of the arm like that, and put it in an area where the drainage is present. Compression, as said, are less in the upper limb. In the lower limb, we had to remove in one case because of infection and of the tube itself. Liposuction is what has already been told by Dr. Suba, in which we is supposed to be done after all the fluid is drained out and you find only fat remaining. After that, you do a proper liposuction. The limb size can be reduced to a large extent, but you have to follow up with the continued compression for a long time. In fact, what Akan Rosen followed was a series of graded compression that used to tie a compression sleeve right there, flatten it, this thing, and then every week or 2 weeks they should tighten it by putting another stitch along it so that the compression was tightly maintained. This is the compression sleeve in place. Debulking surgery, we have been done, and this is the case with the lymphedema of the arm, in which if there are a lot of available, a lot of skin extra also, then you have to take out the skin also. Basic idea is to take out all the extra tissue, make the limb ready for compression so that you convert the limb into a cylinder. You need good antibiotic preparation, compression therapy, make sure there's no fluid, and you can see this, how we had managed with the compression. Arun Rekha did the compression, and we got a very flabby limb. We just excised it, closed it primarily, and this is the patient has sent the photograph herself an year later, and she's doing very well. Another new thing which has been described but still experimental is to do what is called stem cell therapy. Here, instead of taking out the fat, we actually put in fat cells in the area where lymph nodes are present, whether they allow for regrowth of lymphatic tissue. They've done in the upper limb, in the empty axilla, in the lower limb, abdominal fat has been put in the post gynecologic acid. Results are still not very sure, but they have been reported. So to summarize, lymphedema is treatable, should not be neglected. Look for and treat infection first and foremost. They will tell you about the conservative care, but it has to be lifelong. Surgery required in approximately 5% of patients, but it's important and needs a support team at all times. Thank you.
Thank you, Dr. Gogia, sir, for such an enlightening discussion and giving us an insight on the surgical management of lymphedema. Moving on to our next speaker, I would like to invite Aruna Rekha ma'am. She's a course director in Savari Bai Surgical Center, and she's also the India chair of the Learn Group. Over to you, ma'am.
Thank you very much. And you can see my screen? Can you see my
screen? Yes, ma'am, your screen is visible. I just request you to share your slides.
Okay. So, is it okay?
Yes. No, ma'am, yeah, just, I think it's just started. Yes, ma'am. Now we can see your screen, ma'am.
Can you hear me also?
No, ma'am, your voice is not there.
Oh, okay. नहीं आ रहा Okay,
Just
just a minute. Let me start
you have
again.
done it with the video. You have done it with the video, so you stop.
Just a minute. I will start it again. No, let's start from the beginning.
Ma'am, we have your recording. If you want, we can play it also from our side.
Yeah, I
Press
think
the
that,
stop the share.
Okay, yeah, sure.
Yeah, I'm having some issue here. No, no, no. You start here, huh?
No, you have to
Okay,
stop
I'll
the
do
share
it.
from. Sure.
I think you'll have to stop your screen sharing,
Okay, I
ma'am.
stopped.
Then
I
you-
stopped. I stopped.
Yes, ma'am.
Should I start again if you are having issues?
I'll help. I'll help.
Dr. Agarwal?
Yes, ma'am. If you can do that because your slides are having a
Okay,
bit of
okay.
comparison.
Okay, I'll start it again.
Yeah. Yeah, ma'am. I think we have started it. Just wait a sec.
Good evening, everyone.
Yeah,
Greetings
it's
from
it's
Learn
there, ma'am.
India.
It's there.
Congratulations. Oh, what happened?
No, ma'am. You switch off your screen sharing. We'll do it again.
Okay. Good evening, everyone. Greetings from Learn India. Congratulations, Dr. Das, for taking over as Honorary Director for West Bengal Learn India chapter. And thank you for organizing this beautiful seminar. My topic is running a lymphedema clinic in a breast cancer facility. We already know what lymphedema is, but there is a gap in the services. When we look at that, there are no dedicated lymphedema clinics, not only in India, around the world. And when we look at the numbers, so many millions of patients worldwide are suffering from secondary lymphedema. Even in breast cancer, 30% of the patients who undergo axillary lymph node dissection may develop lymphedema. These are the figures. And there is a big challenge. There is lack of awareness, education. We need to educate the healthcare providers and patients. There is lack of specialized care. That is why Learn has put up these centers of excellence, and we can collaborate with each other online also. And we are the one chapter in India. I think Dr. Das will be the second one, and we really definitely hope so. The problem is with insurance coverage. There is no insurance coverage for lymphedema treatment. There's a big hurdle, and we don't even have a properly trained staff for taking care of these patients. This is where we should work together. And the key components of the clinic are a specialized staff, first and foremost, trained lymphedema therapist, physician, and nurses. We need all the equipment like compression bandages, pumps, and other necessary tools. We need the educational resources for patients to form support groups and referral networks. We need to collaborate with our own colleagues and other departments. These patients normally have comorbidities. A therapist in lymphedema clinic, a trained therapist can diagnose and helps in quantifying lymphedema, identifying impairments and disabilities, developing individual treatment plans, utilizing complementary techniques like manual lymphatic drainage, compression therapy, exercise, etc., etc. Assessing treatment progress, regularly monitoring the patient's condition and making adjustments to the treatment plan. Improving patient cooperation, educating patients about the management. Sorry. Lymphedema is a major quality of life issue. The patients suffer from anxiety, depression, fatigue, difficulty in sleeping, and loss of self esteem. The physiological includes pain, numbness, cognitive impairment, weight gain, loss of sexual interest, spontaneous menopause, peripheral neuropathy, and many more. Non-surgical approach to boost lymph circulation, we try to lymph stimulatory focused on increasing the flow of existing lymph vessels. Lymphogenic aimed at encouraging and growth and development of new lymph vessels. These are the two points we like to learn about. And the gold standard for treatment is complete decongestive therapy or CDT. It normally has 4 but now 5 therapeutic measures in 2 phases of management. The first phase is a treatment phase when the patient is in the clinic and with you. Meticulous skin, nail care, manual lymphatic drainage, compression bandage, exercise, self-care education. It lasts as long as necessary. That means depending upon the patient's condition and the grade of lymphedema. Phase 2 is the maintenance phase where patient wears compression garments and also bandages, meticulous skin and nail care, daily exercises, MLD, SLD, whatever is possible, regular follow-up visits, and it is a lifelong maintenance phase. We need to evaluate the patient physically like circumference, stiffness, tonometer, and imaging diagnosis is lymphoscintigraphy, MRI, ICG, ultrasonography, Doppler. Then we can quantify the lymphedema and make a treatment plan. The physical examination is circumferential measurements, measuring the circumference of the affected limb so that we can compare the changes as the treatment progresses. And subjective assessment is gathering information from the patient about their symptoms such as pain, discomfort, heaviness, and limited range of motion. Visual inspection includes observing an affected limb for sign of swelling, skin changes, pitting edema, and we need to assess the pitting edema to make the lymphedema grade 1 or 2 or 3. Assessment or diagnosis is when we examine the state of the skin coloration, appearance, cellulitis for dermatitis, superinfection, reason for consultation, history with appearance, timeline of symptoms, any other disease or treatment associated with it. The presence of a wound necessitates an evaluation for wound care. Maintain skin health. Skin inflammation causes deposition of fibrin and collagen. This leads to the skin thickening and firm tissue consistency. Thickened tissue can compromise lymph flow. Impaired lymph flow increase tendency to infection. So we have to try to bring the infection to as low as possible. Always keep the skin well moisturized. Compression system is 2 types, dynamic compression and static. In dynamic, we do the manual lymphatic drainage or the intermittent pneumatic compression. Static compression is when we use multi-layer compression bandages and compression stockings.
Thank you, ma'am, for this enlightening lecture.
No, I think
Uh,
my lecture, this is not a complete thing. Can I now share my this thing?
Yeah,
My
sure, ma'am, you
screen?
can do that. Yes, ma'am, please share.
Yeah, so let me share it now. Oh, it's asking for a password. So it's okay. I think it's going to be difficult. Can you see my screen? Can you
Yes,
see
ma'am,
my
we can
screen?
see.
Oh,
Yes,
okay,
ma'am,
okay.
your screen is
All
visible.
right, all right, all right. So just give me a minute, huh?
Yeah, sure, sure, sure. Please take your time, ma'am.
So I think I'll start from here, right?
Yeah, start from the slide which was not seen. Yeah.
Yes,
Couldn't
ma'am.
see
Yes.
the
So
full
can you
slides
see
also.
now? Can you see now?
Yeah, yeah, it's fine. It's
Okay.
fine. Absolutely fine.
So I was talking about the compression system, dynamic and static. We have two type of this thing and sorry. So dynamic compression is manual lymphatic drainage, which Pinar is going to talk about in detail. And she's an expert. Intermittent pneumatic compression and static compression is when we get by through these multi-layer bandages and compression stockings. IPC we had introduced in 1994. Since then, we are working on it. It's dynamic compression, and we are now having improved a lot on this. The world has come to the agreement now that IPC is a very good adjunct to the therapy. Earlier, it was considered that only MLT is important, and IPC is probably not that important. But now the opinion has changed. IPC helps in self-management option. It's a very good option. Easy patient application, pressure control, regardless of shape or size. Don't have to bother too much. Does not require much education. Increased adherence. Patients are, it's easy to use, so they will use it more often. It supports the self-management and higher success, therapy success rate. What happened, Shashi? Okay. So external pressure is provided by bandages and stockings, but there is limitation in both. The material properties, limb size and shape, pressure drop during usage, and application procedure. So unless and until we have a very good compression system, whether that is bandages or stockings, we are not going to get good results. And if the results are not good, patient won't be compliant. The result, treatment will not be that satisfactory. So for bandaging, there is a special way of learning and teaching. Laplace law outlines the principles for applying multi-layer compression bandages. Compression gradients. Bandage is applied in a way that creates a gradient of pressure, with the highest compression applied to the distal part of the limb, fingers or wrist, and gradually decreasing pressure as you move towards the proximal part. This helps to move the fluid toward the lymph nodes. Anchoring. Bandage is anchored securely to prevent it from slipping or shifting. Similarly, the layers of the bandages are overlapped to ensure continuous compression and prevent gaps. You can see the result in this lady. She was first given the compression bandages, and then once she reduced and was not reducing further, then we gave her the compression sleeve. But tying these bandages is not easy. Not just what material you choose, but also how you apply and how you transfer that technology to the patient, because it is a lifelong procedure. They have to learn how to tie their own bandages. And once the results are there, they also learn. But it is a skill and an art. You can see this patient. She had come to us with profound lymphedema, but after 1 year of treatment, and this is after the 2 years of treatment, it almost looks normal. Very compliant patient. This Dr. Goge is already discussed. There are complications. No bandage or any system or even compression stockings are without complications. So that is why supervision is required and education is required, and patient has to know when to report. If there are any kind of redness or this, then the compression therapy has to stop. They have to wait for this to heal and find out what is the reason. Is there some underlying infection, or is it because of the wrong technique of the bandage? So compression garments are needed after the decongestive phase of CTT. Most of the time we see the patients coming with the compression stockings in their hands, as that was given to them, and they cannot use it because either size has increased or etc. etc. They have many issues. But once you reduce the arm and then you give the compression bandage, then the acceptance is higher. Acceptance rates with the among the patients. Elastic garments are uncomfortable and ineffective if worn while the limb is edematous. That's what I was explaining. And they do not correct the underlying cause of edema because the pressure in the stocking is not as much as the pressure in the bandage. And in the stockings, the pressure also, though they say it is gradient, but I don't think that there is higher pressure at the lower limb. Sorry, the digital part. So in conclusion, the treatment of lymphedema is a combined modality. Creating new drainage pathways, applying external pressure helps to stimulate the lymphatic system and encourage the development of alternative route for fluid drainage. The compression helps to reduce fluid buildup in the affected limb, alleviating swelling and discomfort. Infections can further impair lymphatic function and lead to increased inflammation and swelling. So infections can damage tissue and compromise the lymphatic system's ability to drain fluid effectively. As you can see in this patient, she had just come to us last week. The affected breast, the left side of the breast, there was a lot of seroma and infection, and which was causing lymphedema more. After reducing that, she is now much better. So along with all these things, we also have to train the patients in exercising. With the bandage on, they have to perform breathing in, breathing out. That also helps. And other exercises increase venous and lymphatic return. So you must think of adding lymphedema clinic to your practice. It will not only improve your patient outcome, also it will enhance the patient's satisfaction, strengthen your reputation, and also increase your revenue. Thank you so much. Thank you. These are the testimonials of a couple of patients. These are few of my patients who.
Thank you, ma'am. I'm really impressed by the results what you have achieved. Excellent results, ma'am.
Thank you.
Moving on to our next speaker, I would like to invite Dr. Pinar Bowman. Dr. Bowman is a professor of physical medicine and rehabilitation and algology in the University of Ankara Medipol in the Department of Physical Medicine and Rehabilitation. Over to you, ma'am.
Can you see my screen?
Yes,
yes, ma'am, it's visible. Okay. It's perfectly fine.
Okay, thank you for the nice introduction, and thank you for your kind invitation, especially to Dr. Das and Arun Reka and all organizing committee. My topic is the role of manual lymphatic drainage in breast cancer related lymphedema. Breast cancer is the most common cancer among women globally and the leading cause of cancer death among women worldwide. But it can also be seen in males, as you have seen at the following picture. With advancements in breast cancer diagnosis and treatment, survival rates have significantly improved and long-term complications like lymphedema have become increasingly prevalent. Lymphedema is a significant and worrisome complication that can arise following breast cancer surgery, lymph node removal, and/or radiation therapy. According to data from various countries, a substantial percentage of breast cancer survivors, up to 70%, are reported to develop breast cancer-related lymphedema, which leads to swelling, discomfort, mobility issues, and emotional distress. Despite its impact, healthcare professionals continue to overlook the importance of awareness and regular monitoring of this condition. It is still a major healthcare problem in both developed and non-developed countries, and it is associated with a substantial increase in healthcare costs. Previous studies indicated that the prevention of lymphedema would be cost-effective, and the costs related to treat lymphedema increases if the compliance to maintenance treatment is not fully provided. Therefore, not only the prevention, but also early diagnosis, treatment, and maintenance are very important. There is no cure, but lymphedema is a treatable and manageable condition. Extensive multidisciplinary management is needed, and the team should comprise the physicians, physiotherapists, nurses, dietitians, psychologists, with the patient and the family in the center. There are also medical therapies for especially the complications of lymphedema. We commonly use physical therapy modalities like laser or kinesiotaping, and of course, psychosocial approaches should also be taken into consideration. But complete decongestive therapy is the main treatment for breast cancer-related lymphedema. It has two phases, as you have seen here, active treatment and lifelong maintenance phases. Both of these phases comprise education, skincare, and exercises. But in active treatment, manual lymphatic drainage and compression bandages are used. And in phase 2, in the lifelong maintenance period, self-MLD and compression garments are provided for patients. Manual lymphatic drainage is the cornerstone of effective lymphedema therapy, but as seen in some of the studies, in isolation, it may not render sufficient results. Therefore, it should be used with combination with additional modalities like compression and/or skincare and exercises. It is first invented by Emil Wader, but later Foldy has progressed this method, and it has become the main part of complete decongestive therapy. It is a manual manipulation, soft tissue mobilization technique, which is directed at either the superficial or the deep lymph vessels and nodes. A typical treatment involves both aspects to truly and logically decongest the system, consistent with our current anatomical and physiological understanding of healthy function, which has been mentioned by Dr. Shuba before. MLD increases uptake and transport macromolecular waste, lymphatic loads from areas of interstitium, and we all know that compression alone may not stimulate the lymphatic system. Therefore, the spatial techniques used in MLD effectively increase the interstitial fluid uptake into lymph capillary network. This filling force, along with the stretch stimulus of skin traction, raises intravascular pressure and peristaltism of lymph collectors, trunks, and ultimately the lymphatic fluid empties into the blood circulation. We can summarize the effects of MLD as you have seen here. It increases the lymph production, lymphangioactivity, it provides relaxation and soothes discomfort. It has also analgesic effects by gate control theory, and it provides a diuretic effect for the patients. MLD is not only used for lymphedema, but it is commonly used for phlebolymphocytic edema, post-surgical post-traumatic edema, lipolymphedema, or complex regional pain syndromes. And we can also use this method for systemic disease causing edema like rheumatoid arthritis, scleroderma, or cyclic idiopathic edemas. There are some contraindications for MLD, as we have seen here. If the patient has unstable congestive heart failure or renal failure, or if she has acute infection or acute deep vein thrombosis, we should not apply MLD. There are also some contraindications for neck area like hyperthyroidism, hypersensitive carotid sinus, cardiac arrhythmia. And we have also some relative contraindications like malign lymphedema, or we commonly do not prefer to apply it during radiation therapy or chemotherapy, as the patients have a sensitive skin after radiation therapy and they have infection risk during the chemotherapy. For abdominal MLD, if the patient has pregnancy or if she is in menstruation period, if there is diverticulitis, intra-abdominal scars, unexplained pain, or recent abdominal surgery, we do not prefer to apply MLD for these patients. When we look to the literature, there are limited studies for the effects of sole MLD. The majority of the studies combine and investigate the effects of combined MLD and other CDT techniques. But we can say that MLD is a safe and well-tolerated technique and adds additional benefit to compression bandaging for swelling reduction. When we compare to individuals with moderate to severe breast cancer-related lymphedema, we can say that the patients with mild to moderate breast cancer-related lymphedema may be the ones who benefit from adding MLD to an intensive course of treatment with compression bandaging. For symptoms such as pain and heaviness, up to 80% of the participants reported feeling better regardless of which treatment they received, but the reduction in volume and increase in quality of life is reported as limited in these studies. In previous studies, we can also see that MLD does not affect the recurrence or dissemination or metastasis, cause the metastasis of the cancer. There are some general principles for MLD. It should be done in a gentle and careful method. The application must be strong enough to avoid gliding over the skin, but instead stretching the skin gently in desired drainage direction. The techniques should not cause hyperemia. The duration should be at least 45 minutes for one extremity, and after MLD, urine output increases. MLD is performed by 4 main strokes. There are pressure working phases and relaxation resting phases. Stroke application should be at a rate of about 1 time per second with 5 to 7 repetitions per area. And the direction of stroke should be towards to the normal drainage areas. We first decongest the central areas, and the treatment of extremities starts proximally and progresses towards the distal regions. Then the stretching direction should be from distal to proximal. Here you can see the strokes. We commonly use the stationary circles. For the extremities, we use pump and scoop. And for the trunk areas, we commonly use the rotary stroke techniques. Here you can see the direction of drainage in a left arm lymphedema. In a patient with left arm lymphedema, you can see the drainage ways. And here you can see the order of sequences. First, we begin from the central areas, from the neck, abdominal area, and then we decongest the contralaterally axillary nodes. And then we open the anterior axilloaxillary anastomosis. And then we use the ipsilateral axillary inguinal anastomosis areas by stroke methods. And we have to apply these techniques also for the posterior axilloaxillary anastomosis. After these central areas and anastomosis, we begin from the upper part of the arm, the cubital area, and then we come to the lower arm and hands. And we finish the MLD with repetitions of strokes in the abdomen and neck areas. If the patient has bilateral lymphedema because of the bilateral breast cancer, we do not use decongest the axillary anastomosis. We drainage the neck and abdomen area, and then we drainage the bilateral inguinal nodes. After this, we use the anastomosis of axilloinguinal anastomosis bilaterally, and then we apply the MLD from beginning to shoulder, upper arm, elbow, lower arm, and hands order. And again, we terminate the MLD with abdomen, drainage of abdomen and neck areas. Self-MLD is also an important part of prevention and long-term care, and it should be done at least 3 times a week. Preferably, we educate the patients to apply this technique to themselves every day. We should educate the patient or spouses in the intensive phase of the CDT, and we have to spend time with patients to the families. We teach them the main principles in an abbreviated method, which takes generally 20 minutes with gentle and slow movements. Like we tell them that the strokes should be like caressing of the baby's hand. And we also lead them to our Turkish Society of Lymphedema and Lipedema website. We use visual materials and brochures, and we can also let them to take videos during the intensive phase and during our teaching methods of self-MLD to them. I thank you for your attention, and I would like to invite you to the 13th ISL World Congress of Lymphology, which will take place in Turkey in Antalya between 15 to 19 October 2025. Hoping to be together with all of you there. Thank you again.
Thank you, ma'am, for such an enriching discussion on MLD. Now I would like to invite once again Dr. Somen Das to deliver the vote of thanks.
Thank you. Thank you all. At first, I'd like to thank Learn International and Learn India Group for giving us the opportunity to organize the webinar. My special thanks to the president of Learn International Group, William Repisi. We got his message. I'm thankful to the overseas faculties. Dr. Pinar Burman is here. Thank you, ma'am. Thank you very much for your wonderful talk. I'm thankful to Professor Andres Zuba. I'm thankful to Dr. Shoshi Gogia. I really learned a lot from you, sir. And my special thanks to the woman behind the whole show, Mrs. Arun Rekha. Thank you, ma'am. Thank you very much for taking the initiative and creating a new chapter of Learn. It's all your effort. We will just work in your pathway so that we can make the lymphedema-free society and lymphedema-free survivors. My special thanks to Dr. Rahul Agarwal. He is with me here working at NCRI Kolkata. He has taken all the pain to organize the webinar, contacting with you people and inviting the faculties and others. My special thanks to the participants. We have more than 150 registrations. Some participated in the Zoom platform, some watched it in the YouTube platform and other different platforms. So my special thanks to all of them who have watched. We will be keeping this recording in our website as well as in the YouTube platform. The people can visualize it later on. People can learn it later on. And this is just the beginning of the new chapter. Let us work together. We will bring a lot of changes in the lymphedema management of this part of the country. We'll be requiring help from everyone, and we are ready to pay attention and learn from everyone so that we can improve on our skills as well as the lymphedema management. So with that, thank you very much. And few concluding remarks from Arun ma'am, if you want to, I would want you to conclude the session.
Thank you, Dr. Suman, for that very wonderful note of thanks, because mostly people forget few things, but I think you forgot nothing. And my special thanks to Pinar for being here. She's a very good friend and she's a very good doctor. And she's always here whenever we invite her to India. And of course, she's very, very generous to invite us all to Turkey. And I'm very sure next year the team will be bigger, Pinar, with Dr.
Yeah,
Suman
sure.
and his entourage. But I'm very, very impressed by your focus, Dr. Das, on not just becoming a chapter. So, Pinar, let me inform you, Dr. Suman Das has just become the honorary president for West Bengal, Learn India. So now we have another chapter here, and with his enthusiasm and with his focus, I'm very sure we will take it forward. Dr. Das, we with Pinar and with Dr. Zuba, we are planning to start some kind of maybe Asia or maybe Euro India,
Eurasia.
Eurasia,
Eurasia.
something we had,
Yep.
we had, yeah. We're
Excellent.
planning to make something like a platform, because they have excellent knowledge and they're very ready to teach. You've already seen that they're so easily approachable. You call them and they come. So what more do you need? All you need is a platform where you can invite people to learn from them. And with you, I think we have a lot of hope. And thank you very much once again for the wonderful effort you have taken, and your team, especially Dr. Rahul. And maybe Pinar, would you like to say a couple of things for our host?
Yeah, thank you. It was a great honor to be with you. And Arun is always working hard. We always are together in many international and national congress of both countries. And she is really my one of the best friends in India and in internationally. And education is very important. Yes, I agree with all the things she has said. And really, I would like to contribute, especially like developing countries like Turkey, India, and other countries, awareness, to increase the awareness and to increase the knowledge of health professionals. This is very important, and we are still many places that we don't have any lymphedema clinic in rural parts of the Turkey, and we have to come together, be together for education and for scientific platforms. And I will always would like to attend and contribute all the educational concepts or educational meetings in the future. And thank you again for your for your kind invitation and for this nice webinar. Thank you.
Thank you. Dr. Rahul, your concluding remarks, please.
Yeah, first of all, thank you, sir. And thank you all the esteemed faculty for letting me participate in this webinar. I learned a lot. Personally, I definitely learned a lot. And I would thank the participants also for giving their valuable time. And last but not the least, I would also like to thank Mr. Somujit. He is the event partner and he has also participated a lot to make this event a success. So thank you, everyone. Hope to meet in this webinar soon. Thank you, sir.
Thank you all. Thank you very much.
Thank you.
Thank you. Bye-bye.
Bye, Pinar. Bye-bye.
Bye.
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 Thank you.